thank you all for very informative and insightful talk. Before we open the floor, maybe is any comment among the speakers to have a comment or questions or feedback? Question for each other? Yes. Okay, so then I have two questions, one for Professor Kumta and one for Philip Chius. Shekhar, you know, the last slide you have, there are many duty to contact, duty to warn, duty to disclose, duty to communicate. I feel like, oh my God, there are too many duties. Then I thought that, what about the duty to care? Then if you're gonna have trying to exercise or observe the duty, then how do you make a balance in terms of duty and the duty to care? Suppose let's say duty to contact, you contact once, there's no any contact, then should you continue to contact or duty to communicate? What about the people had a difficulty with the communication? Would you to provide translators? How do you balance the duty to all and the duty to care?
That's a good question, but the most important understanding is to accept that duty. Once you accept that duty, that there is an obligation when new information comes available. A wonderful case quoted as a research subject, incidental findings, and there's a whole article in New England Journal of Medicine that the first important requisite is accepting that there is a duty. Once you accept the duty, the obstacles of contacting, they become secondary. So, and I think, why is that duty important? Because that is very much part of the care. And the other things become just mere details and administrative. So once we accept that, then you can overcome all the administrative difficulties. You know, failure to contact often may not be because we don't want to contact. Maybe the last known address is not available. But again, the experience of SARS in Hong Kong tells us that when people combine resources together, yeah, you can contact you know, people who are exposed. So I think there was an absolute obligation in the case of SARS to contact the people who may have been exposed, and I thought it was wonderfully done.
Thank you. So, question to Professor Philip Chius. I know that you are the leading surgeon to introduce the new technology in Hong Kong. So when you, before the procedure, so let's say there's a old the intervention skill and operation, and there's a new one. But old are more known and safe, and then new are good but not unknown to the patient. So how, you know, would you kind of, how do you negotiate? How do you introduce new to then? Would you ask the patient to choose one of them, or how do you do it?
Yeah, I think this is a very interesting question because I always face this dilemma, and maybe 15 years ago I introduced a new procedure. It's much more easy than nowadays when I introduce a new procedure. 15 years ago we don't have the internet information that frequently being accessed by the patient and the relative, and we can explain in our situation that we have a new procedure and we are going to do it. But nowadays, a lot of patient and the relative, they will search on the web, and obviously they would know about the efficacy and the safety of the old procedure. But when there's a new procedure coming, and we clinicians believe that this is the best treatment for the patient, still some of them may refuse that procedure because they have gathered information from the internet. So I think we are facing a more difficult and challenging situation, and we need more time and explanation. And of course, if it is a very new procedure that's never been done, it should be under the guidance and application of a clinical ethics approval, while there are a lot more to be discussed. But then if this is a new procedure that's not that new, for example, the procedure that I mentioned before, then I will go through the technology application in the hospital authority, and then we would explain that this is the treatment option that is better for the patient. And we also compare and contrast, and eventually the patient and the relative is going to make a decision of what they're going to choose.
Thank you. So now let's have a question from the floor.
Hi. So my question is to Professor Kumta. I think if I got it right, you mentioned that the duty of disclosure might include things like how the hospital relates to HMOs and how it has guidelines about like X-ray use and so on, right?
That's correct, yes.
So this, I somewhat agree with you, but this sort of takes us to a point where we can also, we should know as a patient what the rate that the hospital has in hospital-acquired illnesses, infections, central line infections, the success rate of the surgeon, and all these informations that are quite relevant. But I think that's sort of taking the whole informed consent idea a little bit out of context, because I think the purpose of the informed consent is that we want to accommodate that reasonable people can disagree in their values, but we can also agree that probably everybody wants to not have a hospital-acquired illness after surgery. So it seems like this should not be individual decision, but rather a regulatory decision. We should have the hospitals regulated in such that or surgeons, such that a particular patient does not have to check all these questions, just like we don't check all these questions in other areas in life, like the airline safety or traffic safety and so on. So,
that's
what do you
correct.
say?
I think what I said, the ambit of information disclosure requirement is quite broad, but that doesn't mean that every patient needs all that information. On the other hand, we should be prepared. For high-risk surgeries, I don't think we should hide away from institutional results. We can't. It's impossible. For small surgeries, maybe the patient doesn't feel it's important to compare institution 1 versus B. Because if you look at autonomy, somebody might say, very high risk of mortality in this hospital, and it happens. I want to go to another hospital. So I think we should be prepared. Likewise, infection rates, people don't want, but in the case of orthopedic implantation, yes, people want to know, because the difference between 0.1% infection and double rate of infection could actually mean a disaster, an amputation. So I think it's a relativistic thing, but we don't need to disclose all that information up front, but I think it's reasonable, especially in high-risk cases, and for the patient to ask.
So, but do you think that's the patient's responsibility to make the decisions, or the regulations to reduce the like if a particular hospital has higher mortality rate because of infections, for example, shouldn't that be a regulatory question rather than a patient question? So, no.
It should be both. I mean, regulatory as well, and the institutions should act if there is a high infection rate for a particular reason. But it's quite complex, because it could also be because of the case mix. You might have a hospital situated in an area where there are much more drug addicts than elsewhere. So it's not easy. But what I'm saying is that we should be prepared to disclose information if it is required. And I'm not putting the responsibility only on patients. Sometimes up front, both the institution and the people who are practicing have an obligation to do that.
So let's have one more question. Yes.
Could I make a remark on that in order to answer the question raised by the particular lady? In some common surgery, well, actually, in UK, the cardiac surgery have have some statistic that was open to everyone, is web available, that about a particular procedure, what is the mortality rate, what is the morbidity rate, not just the hospital. It would be, down to a particular surgeon. All the cardiac surgeons will have their own way of mortality, morbidity in a particular procedure, which is risk adjusted. Now, this concept has been now being employed in Hong Kong by the hospital authority, that they have quite a few of the common major surgical procedures. They have the mortality, morbidity along all the hospitals. So they are available in Hong Kong, and this is probably part of the duty of kosher and for the public.
So for the interest of time, let's have one more question, and we can move on. Yes.
I have a general question for the panel. Whether you've come across a situation where the patient says to the doctor, doctor, what would you do if you were in my position? Meaning that he just wants to abdicate responsibility for making the decision. What would you answer to that kind of questions?
I think it's interesting, having had a couple of recent surgeries that didn't do well on myself. I've had patients asking me embarrassing questions. Who was your surgeon? Would you do particular things? Would you choose this implant or not? I think, you know, for example, if I'm an orthopedic surgeon and I have a joint replacement on myself, I think patients have a right to know which particular joint I have used, because there are about 20 implants and each costs the moon. You have to also balance that maybe my indications are quite different from yours, and that information also needs to be disclosed to the patient. Otherwise, the patient's going to lose trust, because you asked me to use this implant, but you're using another one. Is there a class difference? Am I a first class or a second class? So I think to a certain extent, again, we got to balance it, but I do think there's a right for the patient to ask. You may wish not to disclose it. You're not obligated to do that, but we get this all the time. What would you do in my position? What would you do for your child if your child was affected? I get asked this question because I do pediatric oncology quite a lot.
So I think, just a little bit of response to that question too. I think this is a very essential question. This is something that I always been encountered. So what do you do? Would you receive this surgery if this is, your parents or yourself? So what I believe is that there's an old Chinese jargon saying, 醫者父母心. So I think this is beyond consent. This is something of a practice and a code of conduct, or even how the duty of care for doctors to behave like that. So I truly believe if that's a procedure I believe is the best interest for the patient, it will be the best interest for my father or my mother or even myself.
Okay, so last.
Sorry, just a very last remark. I think the principle that illustrated by Shekhar is about the justice. I think is also probably applicable to that kind of situation.
Okay, thank you, Speaker and Chair. So, thank you.